do a lot of procedures here. We counsel patients on just timed intercourse, having intercourse appropriately and knowing when they're ovulating. We do artificial inseminations where we take the sperm, we wash it from all its fluids so that we're just putting the sperm into the uterus. Advanced reproductive technology procedures to include in vitro fertilization. We then take the eggs and in the laboratory we will fertilize the eggs, let the embryos culture in the laboratory, and then do a transfer where we place the embryos back into the uterus. We also do a procedure called ICSI, intracytoplasmic sperm injection. That's where under the microscope you pick up one sperm and you microscopically inject it into the egg. In addition, some patients will actually come in to preserve their fertility. And so for those patients we will acquire the eggs and then we will freeze the eggs long term for those patients until they're ready to use them. Most patients want to know where to start, what evaluation they need in order to determine how they can get pregnant. And so we want to make sure that we're offering the best possible way for them to get pregnant with the best possible success rates. I think what sets us apart is the standard of care that we offer for our patients, the state-of-the-art facility that we have. We use world-class equipment, which offers our patients the best pregnancy rates that we can offer in the world. I think the people of Hawaii deserve the best possible medical care, and that's what we try to offer. We try to offer a state-of-the-art, world-class facility that's going to give them their very best chance to obtain a pregnancy and a family. I have twin boys that are from IVF. I have a baby girl that is from IVF, so my 3 children are products of what I do. I can relate to my patients, I understand what they're wanting to do, and I understand their desire to have a family, and that's what keeps me coming to work every day. We really want everybody to have a family. That's our goal. Patients come to us because they want to have a family, and our goal is to send them home with a family. Everyone needs to feel comfortable with their physician and the staff that are taking care of them. And that just makes you feel good about going and being seen. But I think really it comes down to how well are you going to be taken care of as well. For infertility purposes, make sure that the laboratory is of sufficient quality. And you need to look at the pregnancy rates. And you can go online and look at pregnancy rates for everybody that does IVF or in vitro fertilization. Those are put out by the CDC every year. So we have national statistics and ways that you can look at different physicians in your area to make sure that you're going to the right clinic for you. Our rates have been consistently in the top 10% in the country, and sometimes even in the top 5%. We work very hard to make sure that we have the very best chances of getting pregnant for everybody. Patients come to us because they want to have a family, and our goal is to send them home with a family. We try to make it as simple for the patient as possible. We try to make it as easy for the patient as possible. We do work as a team so that the patient participates in her own care or his own care. But we try to make it as simple as possible for them so they're not taking a lot of unnecessary injections and they're not undergoing a lot of unnecessary procedures. I think the most misunderstood thing about what we do is the complexity. It's a very complex process for us in our lab and for what we do, but it's not real complex for the patient. So this is one of our large embryo storage tanks. It's filled with liquid nitrogen. It's where we store our embryos, our eggs, and our sperm for long term. What we're going to see today is a semen analysis where we are looking at the sperm to determine if the sperm is of adequate quality and sufficient quantity to allow fertilization to occur either inside the fallopian tube or in our laboratory if we're doing IVF or in vitro fertilization. The age of the female is very important to fertility. For instance, as humans, we were really meant to reproduce in our late teens and early 20s. And for women, as they get older, the eggs get older as well. And those eggs, as they get older, they don't fertilize as well. They don't produce embryos that are as reproductively competent, meaning the embryos aren't able to make a baby. There's a lot of miscarriages in older women, a lot of chromosomal abnormalities. Reproduction really is 80% egg and 20% everything else. Women start off with a little over 6 million eggs before they're born. At birth, they've already lost 70 to 80% of their eggs. And then by puberty, there's only about 10% of the eggs left that the woman's able to use. So a 35-year-old woman will have 35-year-old eggs that may not function as well as 25-year-old eggs. Whereas for men, the sperm is only about 3 to 4 months old. And a 35-year-old man will have sperm that's only 3 to 4 months old, which functions just as well as 25-year-old sperm that was still 3 or 4 months old. With the aging egg, there are a lot of reproductive problems that can occur. PGD, or pre-implantation genetic diagnosis, is very popular these days. What PGD is, it's a way of testing the embryo prior to placing the embryo into the uterus or transferring the embryo for pregnancy. What happens is we grow the embryo in the laboratory to the blastocyst stage. We biopsy the embryo at the blastocyst stage to get a genetic diagnosis for that embryo. Ultimately, we know if the embryo is chromosomally normal or not. There are 22 pairs of chromosomes plus the X and the Y chromosome, which makes you either a female or a male. The genetic testing will look to make sure that we have every set of chromosomes available, meaning that there are 2 1s and 2 2s, all the way up to 2 22s, and then either 2 X's or 2 Y's. So we make sure that the embryo is chromosomally normal prior to putting the embryo into the uterus. Doing the genetic testing, or PGD, on the embryo is vital to producing a normal pregnancy. It's estimated that about 50 to 90% of embryos are chromosomally abnormal. Now, I realize that's a wide range, but it really varies with age. For instance, a patient in her 20s and early 30s may have 50% of her embryos being chromosomally abnormal, whereas a patient in her 40s, 90% of her embryos may be chromosomally abnormal. So the benefit of PGD is it allows us to pick out the normal embryos and place normal embryos into the uterus, thereby really improving pregnancy success rate. If we're placing one chromosomally normal embryo into the uterus for a patient, the pregnancy success rate is somewhere between 70 to 80%, with a very low miscarriage risk for these patients. So this is our embryoscopy incubator, which allows us to monitor embryo development throughout the course of its stage in the laboratory. This is an embryo on day 4 of development, and I'm just watching it, how it's developed in our laboratory over the last several days. So this is on day 1 of development. Now we've gone to day 2 of development with the 2 cells splitting into 4 cells. Now we're getting to 8 cell, which is day 3 of development. It looks good so far, yes. It's important to realize that IVF is not the only fertility treatment available. There really are a lot of other alternatives, but it really depends on what the diagnosis is for the patient and what the evaluation shows. For instance, if the female evaluation is normal and there's just a mild sperm problem, then maybe intrauterine insemination or artificial insemination, where we place the sperm directly into the uterus, could benefit the couple. If you look at the female and there's an ovulatory problem, then maybe just giving the patient some medication to help ovulation occur, which is termed ovulation induction. And then timing it with intercourse appropriately or doing the artificial insemination could benefit the patient. Sometimes we'll find that everything appears normal when we evaluate the couple. And in those instances, then typically doing ovulation induction in association with artificial insemination is appropriate. and can give the patient a viable success. There are many other options as well, but again, it really depends on the patient's findings during her evaluation. For instance, there are some surgical options. There can be fibroids that can prevent pregnancy or polyps inside the uterus, and other surgical or anatomical findings that might be amenable to surgery. As an alternative, some patients need something even more than IVF. They might need donor egg IVF. For instance, the patient whose ovaries have now failed because she's 44 or older, or the patient who's young who still has ovarian failure because of chemotherapy or radiation or some kind of genetic issue. Those patients can undergo IVF using donor eggs. The uterus is still very viable and able to maintain a pregnancy, and pregnancy rates are very good for those patients. Gestational carrier IVF is another option for patients if there is a uterine issue, for instance, severe fibroids or Asherman syndrome where the uterus has severe scarring inside the uterus and which precludes it from carrying a pregnancy, then a gestational carrier might be needed.